Okay, that's fine and noted. Just give me a minute so that we can move on well. Confirm the screen is clear.
Yes, we can see the screen now.
Okay. So good morning once again, everyone. Thank you for joining this third day of our workshop where we are focusing on impact evaluation and of course reporting it. So of course we have been together for the past 2 days. We've now understood really what monitoring is, what evaluation is. We've understood how all this work connects the digital health implementations and link and support to the health objectives that we always contribute to. So we need to focus a bit on how do we really measure the impact, because for the progress and some inputs that we looked at in the results chain that was presented or was shared, we see impact comes a bit at the end, and we learned that whereas monitoring is a continuous process you do always to check if things are really progressing well, for evaluation is more of periodic. So you do it at specific times to check if all what you've done or what you've been doing is yielding to your intended results. Yeah, and the fact that it is that kind of measurement that is trying to assess the results, of course, you don't just do it in any way. So there has to be some systematic ways you organize and put in place to have that kind of measurement done. And of course, measurement here may not mean only numbers and quantitative facts, but even qualitative feedback, qualitative kind of results can also really be measured. We understood situations can be described, and of course, for impact, we'll also see how all this can be measured or described. So with that kind of introduction a bit, so we know today we'll try to handle more about evaluations. And evaluations here, we switch our thinking to some kind of results that come after all the implementation. And these results are either uh, mid-term results or long-term results in terms of outcomes and impact, if you can go back to the results chain that we talked about. So this evaluation session we are sharing today is more concerned to how do we assess the outcomes, how do we assess the impact. So our mind should be triggered to those results that are almost at the end of our results chain that we talked about. Yeah, so within the session, we look at methods, or what they call methods or approaches you use to measure these results or to do those assessment, impact assessment. So there are some known methods from literature and people have really tested them. So they are there to guide us. If you are to measure this kind of results, this is how you approach it. And of course, we'll also look at selection and applying some of the models that these are just examples that we'll use to measure the impact. And of course, as we have always mentioned, where there are various methods, approaches, you always have to select the best that suits your specific project or program or application that you are assessing. And then, of course, we know when we do all these kinds of assessments, evaluations, we have to communicate back what we found out. And this is where we are looking at evaluation reports. How can we have evaluation reports? Are they communicating to the different stakeholders that are in interest of our work that we are doing? Yeah, so we look through all these, look at methods, how we can communicate these findings, and there we'll have understood better how we do the evaluations and then how do we package them to be communicated. Yeah, so as I had mentioned, you can look at this description here that we have. So we have this kind of graph. Yesterday we looked at analysis of data, and I believe now such a visualization, you should be able to look at it and quickly read something from it. So we can use a minute, just look at this figure, and then, of course, this other side on the right, we have a narrative, and then we see what do we really get from this picture.
You can drop your responses in the chat. So I guess Justus has internet issues. So you guys asked what that graph is really saying in terms of what's the information the graph is telling us. But I think he dropped off. So yeah, he's back. Hi Justus, are you back now?
Yes, sorry for that disconnection, but I believe we are on.
Yeah, thank
Yeah,
you.
so do we have members who can share what so far they can tell us from this figure or this view here? So this was a digital health app that was deployed to support some ANC program. And then we see that we are presented with the percentage of ANC visits that happened in Q1, Q2, Q3, Q4.
Hello, okay. Yes, sir.
Yeah.
So
Okay. So
I
go
noticed
on.
from the visualization that ANC visits increased by about 10% quarterly in 2024. Ma.
Good.
Okay. To add to that, it's just showing that over the course of the year 2024, while the digital SMS stuff was deployed, there was an improvement, and clearly it resulted from the fact that these women were reminded daily, often rather, and then it sticks to their head. We had one of the feedbacks here saying this SMS saved my life. I remembered going for my antenatal visits. From the first quarter, there was a gradual improvement, and then over time it improved. And this was because gradually these women started initially it might just be the SMS, but over time the SMS created and a restructuring their algorithm, and they understood that okay, I think over time they even didn't really need the SMS again because they were really expecting it. It was already registered in their head that I have an antenatal care I had to visit. So that's why there was a constant improvement. And getting to the fourth quarter, they were already aware that there is something called an ANC I had to go for. And yeah.
Yeah, thank you both members for your interpretation of this. So clearly, this shows you that, of course, to reach such a point of having this communication, there was a lot of work done. There was development of indicators. There was a lot of work done. The app was deployed, data was collected. And finally, we have this summary out of the work that we've been doing for a whole year. So at least here, at such a stage, you see, you are able to interpret and really put an understanding on what this application has supported and what has come out of all the implementation work that was going on. Yeah, so very well interpreted. So we clearly see some contribution. And from quarter one up to quarter four, we can say, okay, there has been some outcomes because we see improved performance on the ANC's visits. And in addition to the qualitative feedback that was also provided, someone really says, yes, this was important. It helped me to go for my visits. So combining figures with the qualitative data that we also talked about can also bring value, because when you look at the graph and then you look at such an example, it continues to give you a feeling of really how this application was important. So this session is to continue building on this, to show us how can we tell that uh, this was important or not? How do we really come to a conclusion to say, yes, there has been results realized, and we can say these results are surely because of the digital health that we implemented. So we'll talk about quickly about the impact evaluation design. And in design here, we are more talking about the how part and the method. What do we really go through to, or what approaches, some kind of organized work stream or workflow that we follow in order to evaluate results. Here we may be using the word impact, yes, because we are more triggered to measure the long-term outcomes. After doing a lot of work, at the end, you should be able to tell, after a long period of time, you should be able to tell whether the results you are claiming really are a result of your digital application, or maybe if that digital application was not there, maybe you should have also achieved those results. So you are trying to create a different, to communicate something to stakeholders, to tell them that surely these results that we see today, after a long period of implementation, have been achieved because of the digital health. That's something you are trying to measure and communicate. So there are methods here that we will go through and see how basically we handle that. And of course, to do that, we are talking about evidence that is really acceptable. We talked about the good qualities of data, which you very well remember. So when that data that we are trying to use is okay, it means we'll have evidence that we can be confident to present. And of course, we are saying also the stories from the beneficiaries add a lot to the mathematics and the numbers you are talking about. And in that case, you're able to have a feel and you can able to see what changes came into the beneficiaries' lives. And the systematic assessment of the causal effects of the program has to be really done clearly. So here the key terms are systematic, in that there has to be some organized flow. You do your things in so as to come to a conclusion. And the causal effect here, we have a key term here that is about causal effects. Here we are trying to say, okay, can we really say that the results are because of our digital health application, or these results were they could have even been achieved without this digital application. So you are trying to find out if for sure these results were achieved because of the digital health implementation or not. So in M&E, you'll be looking at terms related to causal effects, causal inferences. So here it's all about communicating results that are because of the program or a policy or an intervention that you have implemented. And clearly, in this case, we are not just looking at outputs where you say, okay, I trained people about using this mobile application. I trained people about maybe how to enter data. You're not looking at those immediate outputs of maybe I deployed computers in 100 facilities. Those are outputs that are really not mattering at the end. What we should aim to end at is when we got those outputs, when people were trained, when we deployed computers, are they now giving us changes in our health programs, in our programming? Because if we had expected changes, they are the ones we will measure maybe after a 5-year period strategic plan. So in this case, when we are measuring impact, we shouldn't really boast about the outputs we did in a digital health implementation. So in that step, you shouldn't be jubilating about the facilities you supported with computers. You shouldn't be jubilating about the people you trained or the number of facilities that joined the program. But what is key is to say, when all this happened, we can now see positive trends in our health indicators. And of course, we clearly know that all this that we are trying to measure is important, even when we talk of digital health, because we are trying to prove whether the digital health innovation actually improved the health outcomes. We are trying to make a clear difference between correlations and causations, because sometimes results may just happen as a coincidence. Yes, you did this digital application, but maybe even if you didn't do it, things would have happened. Sometimes that can happen, but now because you implemented, you are trying to make clarity and you are trying to put off those other ideas that people will bring to say, no, even when you didn't bring these things, we are going to achieve our results. So you're trying to really show that your input of the digital health implementation is the one that is causing the changes, not just coincidence. And of course, you have to provide evidence to your stakeholders that have been supporting you throughout the work. And another important element is that as we do work in the health sector, normally we would like the best practices, the working methods to be scaled up. So if something works, it means we should learn from it and be able to scale it up, continue implementing it so that it helps us to achieve more or even ease our work. So in this case, why it's important to really evaluate and show results that came from these implementations is that it can help us scale what works. And in case we learn of anything that didn't work, we stop it or even revise it so that in the next implementations, we do better. So yeah, so this is a kind of graph that is giving you a picture that in terms of outcomes, maybe in terms of the results you want to achieve in your health outcome, we are trying to show, okay, by the time we started the digital health implementation, our results were at this stage. And then we went through a lot of time doing many, many things. And now when we measure, for sure, we see that our results are at this level. So getting this difference of what it was before and what it is now at the end of the program or even at any point you choose to do your evaluation. So getting that difference is exactly the evaluation method that we are talking about, the evaluation that we are talking about. And of course, here the question we are addressing is how much of this change is because of our implementation. Yeah, we've already looked at many examples. I can skip this. So for people from the research background, you may really follow this very well because what we are doing here is a kind of research. It's a study. When you're doing evaluations, they are more a research to answer a specific question. How much results can we attribute to our implementation? So in this case, we have experimental designs and then quasi-experimental designs, which I may say is semi-experimental designs here. And these are general designs that come from the research side. People have been involved in research, in clinical trials. You may already be familiar with such terms. But in the context of digital health, we'll continue to explore more, and then all members will understand what they are. So in experimental designs, as we will see, we clearly do scientific, systematic experiments to prove that for sure, if we didn't have this application, these are the results we would achieve. And when we have this application, these are the results we achieve. And then we get that difference and communicate it. And of course, quasi-experimental design is also answer the same questions, but using different mechanisms around how the experiments are done, as we will see. So in experimental designs, which normally are called random control trials, is where you have the aspect of randomness in how you select your participants that will guide you in evaluating these interventions. So in random controlled trials, this is just a method or a term that makes a method. And this method normally, if you also go into other evaluations in the different sectors, you'll find it. And it's also here. Of course, it's a method. That's why it can cross-cut. And what it is telling us is that we have to do random assignments, participants we have been dealing with, so that some people, we say these are people who interacted with the DICT application, and these are stakeholders who did not interact with the DICT application. And then we try to look at the outcomes in those two different groups. Yeah, so that's the summary about a randomized control trial. And of course, as you assign these beneficiaries, you have to make sure that clearly there is randomness in their selection, in that for people who used the application and those who didn't use the application, at start of it all, they all had like equal chances, but then or you are trying to say they were all in the same factors, you're trying to take off all other factors that might have affected the results. So you're saying, okay, if we clearly say this person didn't use the digital application and this person used it, then you measure the results between those two groups. You can reliably say, okay, the difference is what I attribute to the digital health application. Yes, because in this case, that's why at start we mentioned that implementing a digital health application does not automatically mean success, because naturally we know even if we continue doing our work maybe without a digital application, some results will be achieved. For example, in an ANC program, even if you don't remind mothers with SMS, even if maybe you don't have electronic records at the health facility, to track their attendance and following them up, For sure, there are those mothers who by nature will continue remembering their schedules. They will attend. They will maybe make their own reminders at home, maybe put some calendar reminders in their phones on their own, or even be reminded by their home family members, and they will attend without any intervention of a digital health application. So clearly we see that some results can also be achieved. So when you bring in your digital health application in this case, and you start reminding the mothers, and then you start tracking their attendance and advising them. So when you get 100 mothers attending, it is not obvious that all those 100 mothers are attending because of the digital health application. So the struggle here we are trying to find out is, yes, these 100 mothers have come and very well attended their ANC visits, but then how many of these 100 can we attribute to the digital health application? So that is the exact answer we are trying to look for or find out when we are doing evaluations. And one of the methods here, we've seen that we have to do an RTC experiment that takes off all the biases. And then when we communicate our measurement, it is accepted. And then the other group of designs, with the ones they call quasi-experimental designs, they are also experiments you conduct, but then their level of randomness in how the participants are grouped varies. As we will see, there are a number even beyond this, but in the interest of this session, we've picked these most common ones. And again, you can always really read more literature to understand more designs. And in this session, I will try to make a difference between the RCT and then the quasi designs, and then we see how different they are. So within these quasi experimental designs, we will first look at the difference in difference. That's also a method or an approach. So in this difference in difference, and by the way, as we talk of these methods, I think there are key terms that came in which I may need to explain. Okay, so we have some key terms here: the intervention group, the control group, and at some point we see the treatment group. So in this case, for members who might have not got it clearly, when we are doing these evaluations, remember the example I gave for the ANC mothers, there are those people who will for sure use the application, and then there are those who will not use the application and continue their life. So in this case, when we come to the evaluations, the people who participated in our digital health implementation, who used it, or who really, who used the digital health implementation, we call them the intervention group because they participated in our intervention. And for beneficiaries who continued their life and they really didn't use or get exposed to our digital health implementation, those work as the control group. And the intervention group is also sometimes called the treatment group. So then the control group are those who did not utilize what we are trying to assess. So at the end of it all, our intention is to measure the results in the intervention group, the results in the control group, and then we get their differences. Maybe to say, okay, this difference is what we attribute to the implementation we are evaluating. So now when we come to that difference in difference, we have the participants who participate in the implementation, and then we have the participants who do not participate in the implementation. So it means if you plan to conduct an evaluation in this case, remember we said demand E is not implemented at any specific time later. It has to be really embedded in all your planning. So it means even at start, if you plan to do some evaluation for your implementation, it means you have to already think through how you plan to do your evaluations at the end, so that you think through how you will get these two groups of participants. Because for sure, if you are to do evaluations, there has to be some way you get the control group and the treatment group of participants. So it means at the start, you also have to think through, okay, if I'm implementing this digital health application, either you will maybe implement it in specific facilities, and then later also have the facilities that you don't implement it in, and then you'll be able to get the control and the treated facilities. Or if you just open it, all of them to use, again, we'll see methods that even if you say all facilities use the application, at some point we should also be able to find out how do we compare these results to a method, to a group that did not use. So you have to think through whether you will enroll all the participants, or you will reserve some to work as your control group, or if you enroll all of them, we will also see other methods that help us to find out what do we use to compare the results that we are getting, even when all our participants indeed participated in the application and they all work as the treated participant. So many things in there, but for this method specifically, what it does, you get your participants. Let's say for mothers who really used the digital health application and they followed its instructions. So of course, at start, you have some value that you have been achieving without that application. So for those kinds of mothers, you look at their attendance performance at start and at the end. And then for those mothers who are in the control group, those that you will not give the reminders, or they really don't have access, uh, uh, of course, you term them as control. Either you don't expose them to that application, maybe in a specific region you say, this region will not participate so that it works as our control, or within the same region, some group of people are randomly said these will not participate. So for those ones, you also look at their performance at start and the performance at the end. So when you get their performances in that way, you now come to the calculation to find out what is the real effect of the digital health implementation. So for those that participated, you get the difference. If at start you were managing to get 50% of people attend, okay, I may not put these in percentages since they are beyond 100, but if your performance was maybe at 50 people attending, and now at the end you have a trend of 200 attending, so it means the difference in those who participated in the digital health control is 150. And then for those who did not use the digital health application, if you initially had 50 as your average performance, and at the end you have 100 as your average performance, it means the outcome difference here is 50. So actually, if you are now to say what was the contribution of that application, you would then get the results difference in the participation group minus the results difference in the control group. So when you get 150 minus 50 and you get 100, so it's this 100 that you surely say, yes, this was what the dict application contributed. Yeah. So what you can clearly see is that if someone was not systematic and had not followed the guidelines, they would only look at 50 and 200 and then end up celebrating that for sure the application has contributed 150. Not remembering that there are some people who will have even attended even without that dict application. So for us now to be sure of only that difference contributed by the application is when that difference in difference method comes in to help us get the actual difference in the results. Yes, and of course here such a graph would be trying to put those results on the graph and in a visual way. And that real difference that comes through is what they call a counterfactual. The real, okay, so here we are saying what might we conclude if we just compared baseline to end line for the treatment group only? Of course, we would get a false, we would get a false picture. It's the other 150 that we looked at, which is not actually true. But then if we also consider the control group, it means even when they were not exposed to the dicto health application, they also have some results they achieve. So when you get the difference between the two is when you get the actual figure. So in this case, the term counterfactual is trying to help us really get the difference of what shall we have, or what might have we achieved if we did not get this application clearly differentiated with what are we achieving when we have this dicto health implementation. So of course, behind all those descriptions of the difference in difference, there are calculations that normally happen. And for people who are more in biostatistics, you look at things to do with regulation in order to understand better those differences. So there are a lot of math behind, and of course, for the statistical packages that we use, they already having those mathematical formulas in behind. So for us as M&E participants, we may, if you have a passion in biostatistics, you can always go deep into those models behind such formulas. But if you are not, you just collect your data, basically the data you understand, the baseline values, the end line values, you feed it in the application, and then the application will always be able to calculate all those differences for you in a situation where you have a lot of data points. Of course, the description I used here was just a few numbers, 4 numbers, but when you're dealing with a nationwide implementation, you have many participants. Every participant will have their baseline outcome, and then that data becomes too much. You may not analyze it with your observation just, but you feed it in the statistical applications, and they already have formulas embedded in behind. So for you, just look for the method you need to utilize. If it's difference in difference, if it's any others, we will see. And the application will always calculate that for you. So another method we see here is the interrupted time series analysis. So here we are looking at the sequence. And of course, we are now bringing in the aspect of time to get the meaningful statistics. So in terms of time, you can see a good example is when the pregnant mothers are reporting on their ANC visits. So these ANC visits, they are things that happen at different times. You don't have, it's not something you measure once and say it has happened, but the success comes out of various events that happen. Someone has to visit at week 1, week 2, week 3, and all those recommended weeks. And then the challenge to you as an evaluator is, okay, I have very many data points. I have data for visit 1, visit 2, visit 3, visit 9 up to maybe the 9 months. So where do I start really to say this application helped? So this method around and of course, within those months, someone may miss month 1 and then maybe come at month 2. Maybe at month 5 they miss, then others will miss month 9 and maybe month 8 when they have attended all the past 8 months. So somehow the evaluation becomes complex. But at least this method here where we have those data points taken at different times, and yet we also have some missed points in between. So there is a way the software can always help us to get those points and analyze them. But in terms of understanding, again, it's also trying to look at the same question. We have our baseline, what was happening before implementation. And then when the implementation happens, maybe we see a trend happening. And when a trend happens, as you start your intervention, you have some results. And then as you end your intervention, you also have some results. So now you see almost we have 3 data points. We have the baseline, the before, when we implemented, some results immediately changed, and then when we are ending, also other results are being captured. So we can clearly get the difference between the end and the start of our implementation, and again also try to compare it with what it was at the start for us to get the actual results. So in this case, the behind the scenes, there are such formulas which we will not go to, but here what the concept I would like to deliver is that this is a method that can help us to measure when what we are measuring in here is somehow affected by time and the different data points that we are capturing, when they are not uniformly happening. You have some missed visits in this week, then the other weeks, the visits maybe are many people attend, but the next ones, they will not attend. So at the end of it all, you have to get a way to sum up all those to say, okay, generally, this has been the contribution. Even if 10 people missed in a visit 1, then only 3 people missed in visit 2, then 10 people missed in visit 7. So how do you sum up all those to say, okay, this is the outcome? So this method helps us well, and you can always read more about it. And what I mentioned is that once you have your data points, the statistical methods will always sort out the issue for you. So what you just need to understand is, where do I apply this method? Where is each method best suited? Which kind of data or which kind of situations can this method come in? Okay, so we also have another method called propensity score matching. And of course, it's also trying to answer the same question, but now what it helps us is that it solves for us a puzzle where we have participants that really participated in our program or our intervention. And then we also have those who did not participate. But we cannot obviously just basically compare those two groups, because the two groups, those who attended and those who didn't attend, they may be having their intrinsic factors that limited them that favored them either to attend or that limited them not to attend. For example, in a, in a health facility or even in a district or a region, if you openly say, let all health facilities be supported to utilize a digital health application, maybe to monitor their stocks. So those facilities, you've opened an opportunity to all of them. And of course, at the start of it, you would expect all of them to participate. But then as you continue to implement your program, you realize some of them participated indeed, but others, for some reasons, they didn't participate. So they were knocked off the program. So somehow you clearly now have those two groups. But if you go on to compare the two, just to say facility A participated and then facility A, B didn't participate, so let me compare their results. You will compare them, but in that case, there is already some bias. So because facility B did not manage to participate, it shouldn't be in the right position to be compared with a facility that really participated because they have some other factors that could have limited them. Either maybe in their region, the network was naturally weak and could not facilitate the access to the application. So if you start comparing their results, it means obviously you are comparing people who are in different situations and there is already a bias. So what this propensity score matching helps us, it will help us to compare uh, participants or beneficiaries or groups that are really comparable. So there is a way we first match them to say, okay, if I have my facilities, I have to really first group them and match them to see that they have almost same characteristics. And of course, the factors you depend on to say characteristics, again, they have to be around and making sense and consistent to your program. So you first make sure that you are able to get participants in the control group that are matching participants in the participating group when they have what we would call like the equal scores, or they had like really same opportunity to participate. So in this case, matching uses statistical techniques to construct an artificial comparison group. Remember we said at start, we had opened up this application to all the facilities. So ideally in our design, we did not start with a control group. But somehow, remember, if we are to do that comparison and look for impact and clearly say this is attributable to the application, we have to have a control group. So we are trying to create some kind of control group that was not initially in our plan. And what we depend on are some of the properties of our participants there. So if we are talking of people, then we'd look at things like age, gender, and all those other demographics of people who later participated and those who didn't participate. So we try to compare them. So when you are comparing someone who participated and someone else who didn't participate, then you try to compare when they are of the same characteristics. So meaning that in that case, you are trying to reduce the bias that would come or that would affect your results. So this method is used for program evaluations in the absence of clear assignment rules. Yeah, that one I've already mentioned. At start, if you didn't clearly say, this region will participate, this region will not participate. And for you, you just opened up the application to all regions to participate. So when it comes to evaluations, such a method is good because you use it to create some kind of artificial comparison group. And you are able to have those two groups and compare them and find your differences. So again, how it works, we talked about the propensity scores are things that will be calculated from some of these characteristics we have. For example, here, so they will look at the age and then look at those with same age or comparable, gender with comparable, and so you end up seeing that such a participant matches with this one. So it means when you're comparing results, you will not compare this with others, but compare with the one who they have almost equal propensity scores. And of course, we are seeing this here with our eyes, but when it's complicated data, it's too much, you cannot do it yourself. Again, statistical software packages do that. They have in those methods embedded in. You just have to know which method you want to apply, which properties you want to weigh, and then the software will do for you. So in that case, again, when you have those two comparisons, you come back to now our usual method of looking at results in the control group and results in the participating group, and then you continue to measure them. And of course, as I had mentioned, such formulas you can read and understand more when you are interested, but the software for statistical analysis already have them embedded in. And these are continuing to tell us exactly what happens, whereby the comparison happens. Those scores are calculated from the properties you say that matter, and when they are scored, so the participants or the subjects you are evaluating, they are assigned those scores, and then those scores are compared within those two groups, those that indeed utilized the application and those that didn't utilize the application. And when the matching happens, for example, when we see that A is matched with G, then C matched with J, E is matched with I, so it means this matching has helped us to reduce the multidimensionality of matching variables. And in that case, we can easily say A and G can be easily compared, B and F can be easily compared, and our results will not be biased. In terms of the steps, I've already mentioned them, but specifically, when you compute those propensity scores for all units, of course, it's not you calculating, but the software. Then you do the matching. Again, the software, after calculating those scores, it will match. And after matching is done, so then the difference is calculated. So almost you go back to the difference where you are trying to calculate differences in those that participated, and then differences that in those who did not participate. Then you get the average differences to estimate the real effect. So the average difference in those who participated, and then the average difference in those who did not participate. Then you compare those two average to get the actual situation. So many methods continue, and I see somehow time is also running. But then we have this other method, which is regression discontinuity. And what we can see is that for it, it's more used in programs that have a continuous eligibility index and with a clearly defined eligibility threshold to determine who is eligible and who is not. The cutoff must be unique to the program of interest. There should be no other programs apart from the program to be evaluated. So as we deliver these health services, sometimes these interventions, different interventions come in to support different groups of people. So you may say, okay, in this time we are in, maybe when we talk of the HIV care, or yes, HIV care, you may look at all the people that are under treatment and say, okay, maybe the people who are not following up well with, or who are not doing well with their treatment, are those that we will target. So when you say that this DICT application is for only people who are maybe not responding to treatment, so that becomes some clear eligibility threshold. So it means whereas you have all your patients that are getting treatment for a specific condition, you're saying only those who are not responding well to the treatment will join this digital health application for reminders. So at that point, you clearly see that some people will automatically not be in the participation group, and then the rest will remain in the control group. And as you move on, obviously, the people who have joined the reminding system will
Justus, we can't hear you. Justus, are you on the call?
So I think Andrew is on the call. Hi, Andrew, if you can hear me, please. I guess you can continue.
Yes, hi Vivian. You can hear. Could be internet challenges. Apologies, I couldn't join a little bit too early. Had serious power blackout and internet blackout as well, so I had to move for like 15 kilometers to where I could get some access. So apologies to our dear participants. You can, I think, take back the slides, then I'll pick up from where just as I stopped.
Okay, so I guess Justus was the one sharing the screen, but let me see if I can also do that my end.
Yeah, I can share, and I hope you can hear me.
Yes, Andrew,
Yes. So in the interest of time, Andrew, I see we have like maybe 20 minutes left. So I ask that you take it on from this point. I had started on it, but you can conclude and then we continue in that direction.
All right. Thank you, Justus, for the wonderful presentation thus far. So to pick up from where Justus has stopped, the RDD mainly we consider uh, having a very clear cutoff point. And if a program cannot have that threshold, then this methodology or this technique is impossible. So we need to have a clear score to know how to create a benchmark between those that we shall consider as participants in the program and those that we shall consider as or help create a counterfactual to help us benchmark or create the impact. So next slide. So what we do, we get the values at the beginning of the program before they start participating, considering the threshold. And after that, so you calculate the scores for both participants or both sides, and consider those who are next to the cutoff points are the ones you consider. So the example here was on agriculture, but let's take, for instance, you want to develop a hub and you want to know the impact of that application. And for instance, let's say it's an application that is going to be dealing with hypertension. So we shall need to have a very clear cutoff point for which people are we going to consider. So we need to have a clear level of the BP. Those who are under some particular next to the cutoff, you consider them, and at the end of the day, we see the difference. So this is just a scenario of what happens at the start of your program. You see where there are many dotted lines this side and this side. So this at baseline, these are the values. You can take the next slide so that I can explain at once. Yes, so we have a clear cutoff here at 50. So if we are considering the BP level at 60, if we are considering the BP level at 50, for instance, so we can see the difference between at baseline, we saw that they were all together, right? If you saw the other graph. So now, after intervention, you can now see the difference. So this is how we calculate the impact is actually A minus B, because you can see that after the intervention or after you implement your application, you can see that the lines that were all together, you can see the gap. Those with the big dot lines have increased, and you can see that this on the right has a decrease. So the gap or the difference between A and B is the actual impact. It tells you the actual impact. And you consider those who are around the threshold. But the farther you go far from the threshold, the greater the variance. For instance, you can't compare those around 20 here and those around 80. It will not give you accurate. So you consider those within the threshold. For instance, it could be, let's say, 48. You could be, for instance, 48 and 52. Yeah. Next slide. So under regression discontinuity, there are two kinds of scenario. We have those who comply and non-compliance. So for those who comply, you will see that there is usually no manipulation. And for you to use this methodology, you must really ensure that you are catering for these two factors, manipulation and no manipulation. So you see the eligibility and those who are not eligible, but that is where there is no manipulation. So how do you check for this manipulation? Okay, you must make sure that you conduct this curve at baseline to find out if there is really a manipulation or there is no manipulation. And once you do this at baseline and you find that your curve is falling where there's manipulation, then it is very, very impossible for you to conduct or carry out the regression discontinuity methodology. Okay, so how to check for validity? There are two ways to check for validity. You can either plot a distribution curve at baseline, just like the previous one. That was a plot distribution curve to find out if there's manipulation. Next slide. So the Chapman and the Fuzzy regression discontinuity is also another method to check for compliance. You can see that the first graph here, this is a sharp, and this is mainly for where compliance has been met. You see that those who are eligible had a flat curve. Those who are not eligible, sorry, had a flat line. But when you check on the fuzzy, these are non-compliance. You see that you see how the line is a bit slanting for those who are eligible and also for those who are not eligible. You can see. So the sharp and fuzzy regression discontinuity is also another way to check for compliance when you're dealing with the regression discontinuity. Next slide. So the IV, the instrumental variable, this is a methodology that deals with the prediction. So you'll be having about 4 variables, and out of the 4 variables, you have key assumptions to consider. One, there must be relevance assumption. There must be exclusive restriction and exogeneity. So here we want to assume that if you see our equation, we have Z directly affecting X, and X is directly affecting Y. And then we have this U, which is also affecting X and affecting Y. So what are these variables? So Y is our outcome variable, is the outcome. And X is the instrument. So what do we assume here? We assume that Z can only influence Y through X. That is relevance assumption. It cannot affect Y directly. It needs to affect it through X, through our instrument X. Then U, which is I would call U is our external factor. So there must be no relationship between Z and U, exclusive restriction. There must be no relationship between U and Z. So it means this external factor should only be able to influence Y and X, but not the Z. That is the assumption. So I would give a scenario. For instance, if you're developing an application, if you're developing, let's say we want to develop some application that could maybe help in reducing or will help the community to reduce on cervical cancer. So we want to say, okay, what are the relevant variables that we could think about? We want to develop an app, and the ultimate goal we want to see is a reduction in cervical cancer, or could even be uptake of HPV vaccine. So you want to think that there must we need to think that, okay, if we develop the app is Z, and the outcome, which is either uptake of the HPV vaccine or awareness in cervical cancer issues, then you can think about X, for instance, being issues to do with, for instance, I would say age. So you want to look at, is there a relationship between age, okay, age of the participant, age of a patient, is it related to the ultimate outcome? Okay, so if we develop the app, will the age of the app of the patient affect the ultimate outcome? Either it is the uptake of the HPV vaccine, or or the sensitization or awareness issues of cancer prevention. Is there a relationship? Okay, so will the app be able to influence the patient directly in terms of it going for the vaccine, or considering the awareness sessions or the prevention messages about how to prevent cancer? That is just an example of how these variables interact. Then you could also think about other external factors, such as peer influence. Okay, but so that's how these variables interact. So you must really make sure that your external variable has no direct influence on Z. Next slide. So there are two scenarios, or there are two equations that usually we run them out when using when using the instrumental variable. There are two stages. So these are what you compute on the software, and it runs in the back end. I will not dive into them in details, but it's about the relationship between X, Y, and Z, and some constants. For instance, beta naught and beta 1, and the external. So, but the most important thing is that when using instrumental variable, you must be ready to use or move to advanced randomized promotion methodology. So randomized promotion is another method, but it can also work very closely with the instrumental variable. And in most cases, we call them encouragement design. So here you actually have about 3 groups that you're dealing with. You're dealing with the compliant group that we call them the always taker. Then there are those ones who, whether you even go and lie down before them, they can never comply. Whether it rain and it shine, they cannot comply. So those are the never. the never group. Then we have compliers, compliers or enrolled if promoted. And this is the logic between randomized promotion as an instrument. So you develop your application still with reference to the cancer. You develop your application and I'm in a meeting, I'll call you back. So you develop your application and let's say in one region, you say, okay, let's promote our application in this state. Whereas in the other state, we don't promote. So we shall do all it takes, put their adverts, do some community awareness, put radio talk shows, do community awareness, put our posters to promote our application that there is this application, it can provide real-time information or messages about cancer. You can know how to prevent, what to eat, what are the signs and symptoms. So once we do that kind of promotion, we shall see that we shall have some compliance. So that is what it means that by compliance or enrolled if promoted. So we shall now enroll or have more people complying with the intervention. Next slide. Okay, so that was about the impact designs, which are a bit so many but maybe briefly before I even enter on the slides, the designs we have seen, those are mainly quantitative, but there are also other qualitative designs that we can really use on impact, because someone might be asking, so if I don't design my intervention with this kind of advanced methodology, can't I track impact? Or what would be another alternative to also track impact? So we can also track impact qualitatively. We have been assessing impact qualitatively using some advanced methodologies. But the difference is that these designs or these methodologies that we have talked about, these are mainly cause and effect, attribution, or the counterfactuals. They deal with counterfactuals. You can clearly have your cause and effect relationship, just as mentioned. But now with the qualitative, it's not the case. We now move from attribution to contribution. So we just focus on what has this intervention contributed, okay? What has it contributed? So instead of focusing on attribution or the cause and effect, we now look at the contribution. So there we don't have counterfactuals. We also don't have the cause and effect relationship, but we focus on what contribution has been as the intervention made in the lives of the community. And there are methods like outcome harvesting that you can use. There are things to do with process tracing. There are things to do with the most significant change stories. So those are some advanced qualitative techniques that we can also use. And we call it contribution analysis that we can also use. Now, when it comes to writing M&E reports, this is very important because you need to know how to communicate your results or communicate your findings. The principle is straightforward. You need to be clear. There is no jargon when it comes to writing an effective report. And there are so many evaluations reports that are always published every day. If someone could just go online and just type in and see evaluation report for anything you want, I'm sure you can get and see how the different people structure their reports. There could be something unique. There could be something in common that cuts across the different reports in terms of the structure. If you're using visuals, you need to know what kind of visuals to use and whom you're reporting to, the donor, the community members, the policymakers, what kind of, what charts are you going to really put? and you must communicate something, some actions, especially on your recommendations. Okay, so that's how you can communicate your report. Next slide, but I want to hint on the structure. If you look at the different reports that uh, uh, are on the web, I wouldn't want to say there's really a cast in stone. I don't think there's a cast in stone because different organizations have different policies and they have different kind of structures. Okay, but these are the common things that, just like in any other report, shouldn't really miss. Even if you are an undergraduate student and you're making your dissertation report, you're a master's, you're a doctorate student, you're making your report, at least these are common. So you have the executive summary. Okay. For some people might not really have all the time to go through everything in the report. That is the reason for the executive summary. Then, of course, the introduction, which is very purpose, and sometimes have introduction background, sometimes you'll see context, and so on and so forth. Methods, which is, I can say, there is no report, no evaluation report that will lack a method. Never, it will not be there because we want to know, how did you carry out this assignment? So you need to tell us, what design did you use? If it was impact evaluation, what design did you use? Did you use RCT? Did you use DID? Did you use instrumental variable? Did you use a qualitative? Because we really need to know, it must be explicit. What approaches did you use? There are so many approaches that we use in M&E. You will hear of feminist approach, you will hear of participatory approach, you will hear of so many approaches, you will hear of system thinking approaches. What was the sample size? It must be explicitly. We need to know how many people did you assess, how did you even sample them, and so on and so forth. The evaluation matrix must really be there in your M&E report, in your evaluation report, analysis, and so on. This is not all. There are so many things, ethics, ethical principles. We need to know, what ethical measures did you put in place, stakeholder mappings. So there are really so many. I would just advise that if you can just go online, look for some of these reports, and we study them critically, okay? So that you can even benchmark and see what is your institution doing. If they do some evaluations, have interest to look at the report, okay? Don't even feel shy that you're not in the M&E department, you don't need the report. No. Feel free to ask the M&E unit to share some of the evaluation reports, whether it was done externally or internally. Findings, you need to present how your findings, either in terms of visuals, either in terms of charts and so on. If it is a qualitative, we need to know the themes, the quotes. Then, of course, the recommendation and sometimes conclusion and annexes. But like I said, there is no cast in stone. Different organizations have different approaches. So you might approach another organization and they tell you, our report must be structured in this way. So you might see other sections which are not there. Then the dissemination plan. This is very important because it helps you to know which category, which stakeholder group are you targeting? What information do they need? Under what medium or mechanism or avenue are you going to reach out to them? What channel are you going to use? So if I could just pick, for instance, the first table, the first row, which is MOH, Ministry of Health, being our stakeholder or target stakeholder group. What information do you think they need? We see, for instance, they might be interested in evidence of improved maternal attendance, okay? The maternal attendance outcomes, which is quite different from from what the donor might be interested in. The donor might be interested in the actual impact, the cost effectiveness, scalability issues, and so on and so forth. So this is just how you can think through how you are going to disseminate your findings. You could also think about some bit of what key aspect or what key action points would you want each stakeholder to have. Next slide. So how do we then use M&E insights for funding and policy? Yeah, I would say it would be like a big waste of resource for us, for you to do all your M&E stuff. You have a lot of digital application and you assess it and you keep the information, you know, you keep the information. So this information is very helpful because it can help you to get funding. You need to see how to package it very well so that you can really lobby for some funding, but also push for some policy changes. So just like you saw the dissemination plan, if your application or your intervention is focusing on policy, you also need to have a policy plan in place, a policy dissemination plan. Okay. So think through why the advocacy is very important, because the data might not really put a lot of cause. So you need to add the advocacy component so that it can really, if you had the data, the evidence you've gathered to really push for this cause, it can really turn things around. Looking at how we can turn evidence into influence, yeah, you could think of using policy briefs if you're targeting the policy makers. You can think of developing some dashboards. Yesterday, we already saw how we can go through developing dashboards and what key indicators you can think through. You can think of having success stories, very, very important and very powerful to back up the numbers. Then, of course, some panel meetings, some panel discussions. So a lot of things are changing over time. These days, policymakers, donors are really giving priority to panel discussions. So those are some of the high-level meetings that you could think about on how you can present. If they give you 5 minutes, then very fast you can present your one-page summary so that they see what discussion to pick. Then, of course, M&E could help us very much in fundraising or resource mobilization. You've come across a call for proposal. You want to solicit for funding, even if you just want to organize some bit of fundraising, you need to use some M&E techniques. Think about how to bring in some evidence. You could think through the costs that will be incurred looking at the scalability. If I do this in one state, what is the cost of one individual and what is the cost of 100? So that is where you can employ some costing techniques, some cost effectiveness analysis to really see what is the health outcome, what is the quality in terms of what quality, the cost of one quality per person. Next slide. Yeah, so that is it regarding impact evaluation and how to report our findings and how we can use findings to solicit or outsource for fundings from the different donors. And I believe that this session has been very helpful to all of us. And we can think through how to apply or start applying some of some of this knowledge. We're always there to support all participants. Anyone who is always interested could feel free to reach any of the facilitators, even at Digital Health Africa, to see how best we can support if you have any M&E challenges, you have things we can improve. So thank you, and over to you, Vivian. But maybe before I hand over, I would want to apologize again for joining late. Wasn't intentional. It was unavoidable circumstances, but I wanted to try all I could to join earlier. So over to you, Vivian.
Thank you so much, Justus. Thank you, Andrew. We really appreciate your intentionality of joining despite the challenges that you had. So right now we shall get to the session for questions and answers. Our facilitators are at hand, waiting for you people to air your questions. You can choose to unmute, and you can as well as choose to type on the chat. So the floor is open for questions.
Okay. Thank you, Lucy. Maybe as we wait for the questions, I wanted to ask the participants in here, is there anyone who is working on cervical cancer or HPV vaccine? If there's anyone, whether from Zambia, whether Zambia, Malawi, or even Nigeria, Ghana, or just anyone on cervical cancer. I don't have a question for the person. Most times people fear that we shall ask them questions, but it's for something very important that I think we could discuss further if there's someone in that field. Okay, back to the participants for questions.
Thank you, Andrew, for really offering to help and furthering the conversations. Participants, the floor is open for questions.
If they don't ask, then we, the facilitators, will ask them.
Great idea.
Members, or you can check people online on YouTube. Any question?
Or as we figure out the question, someone can unmute and just comment on how the session was.
I see there's a question in the chat.
Oh, they're coming in. You can pick them up from the chat, Andrew and Justus.
Okay. Belete is asking, how do we determine the evaluation methods and the parameters? Okay, so how do you determine the methods? Is that let me even start with the evaluation design. So because now for me, I am an evaluator, and this is where I come in from. Most of the programs are always implemented from other dimension. And when we come on board to do the assessment or the evaluations, we find that it is not possible or applicable to employ the RCT, the DID, the what. So these designs that just started speaking about since morning is that it must start from the project design, okay? It must start from the project design. It's not something that an evaluator can come in and say, okay, I can employ RCT to assess the impact of this project. So from the point go, when the project team is putting up their heads together, they need to have this aspect of how shall we assess impact at the end of the day. So if they have that M&E aspect, they will say, someone will say, okay, I think let's not do a RCT because it may not be so ethical. We don't have enough resources, but maybe let's do a DID. We just have a control group or a comparison group so that at the end of the day, they are able to have. So to determine the methods, you need to know the project design. What was the project design due at inception? So from experience, when we are always clients put out this calls for that they want to do evaluation, and how do we determine what evaluation methods can we employ? For instance, can we say, okay, since there was no control, since there was no that aspect of creating a counterfactual, a randomization, then let's do a contribution analysis in addition to the casual or the non-experimental of having endline and doing a baseline or having that kind of comparison. So you focus on the issues to do with the project design, you look at the scope, because, for instance, you may be limited also with the budget. So there are very many other parameters that you really need to think through critically for you to say, okay, I'm going to use this method because some of them are very expensive. For instance, RCT it's not a cheap method. It's very, very expensive. And there's a lot of critiques, especially on ethics. So those are some of the things that you need to think through very well when determining. Justus, in case you want to add anything on that particular question.
Yeah, thank you. And you've, of course, shared all that is necessary. And of course, critical to that is that part of the planning team should, of course, have the skilled team members who will be able to look at all these factors that Andrew has mentioned. So someone with the skills who know what evaluation is, who knows what different methods are in place, and is skilled, is able to analyze all that, look at the program design, look at the possible methods and compare and easily choose the best suitable method. So the skill here is very important in all this that we are talking about. Over.
Yeah, thank you. Thank you, Justus. So those are really very important. Another time frame, another parameter would also be the time frame. I remember for my master's, I wanted to use the interrupted time series. And someone told me, I think you will not finish Makerere. So time frame is also very, very important. And there are really so many other parameters. Okay.
There are two more questions on the chat, Andrew and Justus.
Sato, I think he's asking when are they supposed to submit their projects tonight or the deadline has been extended. I think, Lucy, you'll put some clarity there. Someone is saying Wednesday.
There's
Okay.
one for how do you determine the evaluation methods and parameters?
That's exactly what we've just answered, and there are no more other questions here.
All right. Thank you.
Yeah.
Thank you. Thank you so much, participants, and thank you so much, facilitators, once again.
Maybe there's a question on the stream on the YouTube. It reads, how can impact be measured when there is no control group, especially in a country or where a project has never been implemented before? So I can repeat, how can impact be measured when there is no control group, especially in a country where a certain project has never been implemented before? So Andrew, you can give more guidance on that.
Okay. So it's very, I've conducted many impact assessments, many impact evaluation where there are no control, actually most of them, because these designs that we have talked about, they are very expensive. So most people, very expensive, you need high technical people, but also you need a lot of time and stuff. So most people don't use them. So most of the impact evaluations that personally I've conducted have been where there are no control groups. And just like I hinted earlier on the qualitative, so what we do is that if there is no control group, we at least advise that there is a baseline. So if there was a baseline conducted at the start of the program, then maybe they can do an end line. And that is what most projects are actually now doing. So when they do that, they're able to do some bit of comparative analysis between end line and baseline. But remember, there is no control group. So the counterfactual group is not there, or what Justus was talking about. So you can't compare. So you'll have that change between a baseline and end line for only a single group. So you cannot really stand out and say, this is the exact outcome. But if you had the counterfactual, then you would do the DID. Now, once you do that, you can now add some advanced qualitative methodology, the contribution analysis. So the contribution analysis will now focus on what the intervention contributed, considering that there might have been so many other factors that are contributing to the observable change. But the contribution analysis will now pick and explain the other changes that we observed in our baseline and end line. So in simple terms, you can assess impact using contribution analysis, using advanced qualitative methods like contribution analysis, outcome harvesting, process tracing to really dig out and even do some good case studies to really attach meaning to the observable changes that we are seeing between the end line and the baseline. Now, if the program has not been implemented in that country before, then you might need to rely on secondary literature or secondary data. If you have access to the DHIS2, if that country uses DHIS2, you can get some data set. You can rely on some surveys. For instance, we have the demographic health surveys. If it's you can use census data and try to see what was it in because these are large surveys that are done. For instance, after every 5 years. For instance, in Uganda, we have, for instance, HIV impact assessment, which is done every 5 years. But it's called HIV impact assessment, but they don't even use the impact designs that we have talked about. But they tend to say, okay, after every 5 years, what is the change like? Okay, so those are some of the techniques that you can use. You can now rely on secondary data source. You could also think of doing some rapid assessments to back up the secondary data that you have conducted some analysis on. So that is how we have been going about assessing impact for programs that has no counterfactual, for programs that maybe has not been implemented. So you tend to rely on secondary sources. What has been done? You also look at other countries, okay, and try to put some contextual interpretation. I hope that answers, but just as also in case you want to add any other thing.
Yeah, well explained, sure. So Andrew, in that case, when you look at the difference in different, the propensity score matching method, can it also be a method that directly addresses that question, that problem? Because then you're able to look at the participants and then kind of create an artificial group that can work as your control group.
Yeah. You have a point. Actually, I have a colleague who used that on some education program. So he created that kind of artificial. So here you need to have the covariates. You need to have those variables: age, gender, education level of income, level of what, those things. So once you have those variables, yeah, you can easily create a temporary counterfactual group that you will then use to benchmark or get the actual impact. So that can also work very well if you can have those variables.
Yeah, thank you. Over.
Okay. Once again, thank you so much, Justus and Andrew, for the Q&A and the session. The participants, in case you get a question before we close the workshop at the end of the day today, you can actually share them personally to Andrew and Justus. They share their contacts, or you can pass through them the digital health contacts. That said, allow me to invite Vivian to give us a brief on how the session, which is slotted for today, 4 p.m. West African time, is going to pan out. Vivian?
All right. Thank you so much, Lucy, Andrew, and Justus for the session thus far. So just as we wrap up, this is a quick announcement to share that for this evening, which will be the final closing session for the workshop, if you would like to present your case study for Justus and Andrew to give you live feedback, please, you need to send it in PowerPoint to our email before the session so that we can call on you to make your presentation and get a live feedback. We won't be able to take more than at least 3 to 4 persons. So the earlier you send it, the better. So once we have 3 to 4 submissions before 4 p.m. West African time today, we would close that slot. So please do send. Some of you have sent it in, but please send it back in a PowerPoint format so that we can, in case you are not able to share your screen, we can also share for you. It's more easier that way than the document or PDF format. So that's what we'll be having this evening. Also, for this evening, we'll also be launching the advanced fellowship rather, for our for this program. Okay, so let me share my screen so we can see that the overview of this evening's session. I hope you can see my screen. All right, so this evening by 4 p.m. West African time, we'll be having a live chat with the experts where we'll be asking them just a few questions that some of you had sent in to our email online, questions around career skills that you need to get to do M&E in digital health. What are the career pathways? How can you get more involved? What are the career opportunities? And other questions, just about 4 to 5 of them, that our experts will have a discussion on. Then we go into the case study. About 2 to 3 case studies will be presented. As I've mentioned, if you like to present yours, please send the PowerPoint to this email. Then we have the final quiz, which will be up to, I think, 20 questions from across all the sessions we've done so far. So please come prepared, and we will see who the final winner would be for this cohort, and the person will emerge as the winner of the workshop quiz. So please come prepared. It will be a combination of all the sessions we've had so far. And lastly, we'll be launching our advanced fellowship on M&E in digital health. So you come so that you can hear more about the program and how you can be a part of it. As you've seen, this is just a 3 days crash course. We went through a lot of things very fast, but we are launching an advanced fellowship where we will go more deeper into all of these curriculum for a longer extended period of time. Okay, so do not miss this session. This is a session you don't want to miss. It's fully packed, so please let's come prepared. Thank you all, and we'll see you in the evening. Bye.
Bye,
Thank you,
everyone.
members. Bye.
Bye. Thank you.